Good evening, everyone. Welcome you all to Oncology Classroom evening session. As you all know, in this month of August, we are discussing different talks on pediatric oncology. In continuation with our earlier talks, today we have a very interesting topic on sparing hippocampus in pediatric patients, need of the time. And we are very fortunate to have Professor Rakesh Jalali with us, who is the Medical Director of Apollo Proton Cancer Center at Chennai. Dr. Jalali was faculty at TMH Mumbai for a long time, where he was instrumental in developing neuro-oncology program. We are really very thankful to have sir today with us. Thank you so much, sir, for accepting this invitation and finding your time in your extremely busy schedule. May I now request you to please take over the session and start your presentation. Thank you once again.
Okay, good evening, everyone. It's a bit late in the night, but I hope it's more after 8, but I hope you guys have finished your work now. And I'm thankful to Dr. Mondal because he has taken the pains to organize this nice educational sessions. It's slightly different times these days, but as we were discussing that sometimes these very concentrated webinars are perhaps more fruitful and you tend to stay there and the concentration is also there a little bit more than if you are going to the general kind of an oncology meeting. And I'm also thrilled that so many of you are participating in these meetings, and in particular that themes have been chosen. In Apollo Proton Cancer Center, we also have a theme, we call it WOW series, which is webinars on Wednesday. Some of you may have already seen it. We do it twice a month. And so today we will talk on hippocampus and neurocognition in general. So since the theme is childhood cancer, so therefore it is appropriate to again revisit the survivor and survivorship in childhood cancers. And now all of us know that a good number of childhood cancers, not only in brain, in general, about more than 3/4, 70, 75, 80% can have a long-term survivorship. But as was shown by St. Jude's data and others, first time in 2009, subsequently in NEJM, and there's a recent update too, of 20,000 cohort patient now, that a quarter of them die actually by the age of 30. They can die because of the recurrences per se, but they can also die of second malignant neoplasms. They can have significant morbidity because of CVA, post-treatment vascular events, neuroendocrine, growth deficiencies, and of course the neurocognitive dysfunction too. So this is a significant survivorship burden, especially in CNS and head and neck cancers. And this has been one of the focuses of modern treatments, in particularly radiation, and all of us are in that field because sometimes we do have to treat our young people with radiation therapy. Now, this was an interesting kind of a early data to suggest that neurocognitive function in childhood brain tumors may actually also have some implication about the demographics, whether they are from lower socioeconomic status, whether they are not whites like African American or Hispanics. And this was among the earliest data that showed some focus on that. And we also realized over a period of time that causes of neurocognitive dysfunction, particularly in children, can be because of the tumor per se, can be because of patient-related factors, treatment. We'll talk, of course, much more detail of radiation point of view, but we also have to remember that it is a multifactorial cause of neurocognitive dysfunction or failure that we see in our childhood brain tumors. And there are other parameters, including surgery, anticonvulsant, steroids, that we give to our patients. Now, as we just discussed, and I was trying to show you this issue of the demographic pattern of the childhood neurocognitive dysfunction, we also know that neurocognitive dysfunction is seen fairly common, both in the short term as well as in long-term survivors. It is reasonably well recognized that verbal, non-verbal cognition, there is a decline of at least one standard deviation below the mean that you have. And usually the problems in very simple terms are about thinking, learning, remembering, mainly in the processing speed, verbal memory, and so on and so forth, as we will discuss as we go on with the talk. This was also seen in our own data, and this we realized many years ago. And there was some data as also from Boston. This Carpian theory data was from Harvard, and they showed about less than a 50%, 45% of the patients before they started radiation, they had a poor IQ. And I've shown this data many times before, that in our cohort, in a prospective study, about 60% of the patients had a pre-radiation baseline which had below normal level as compared to their siblings and as compared to the normalized value as which relevant to that age. And we tried to see what could be the different causes at the baseline value about the neurocognitive burden in these children with brain tumors. And we found out that it also had an implication on the education of the parents. The children whose parents had very low and primary education as compared to higher education, their children tend to have poorer IQ as compared to the others before they start radiation. And that was quite interesting. We also wondered, is it really because of everything can be put together because of the socioeconomic status and the demographic societal burden that we have? Or is it really the tumor which makes the difference as well? So what we did was, I was very fortunate, Dr. Banavali, our colleague who everyone knows, had collected some pre-chemotherapy baseline IQ data in children with ALL. So we compared the two, a cohort of brain tumors as compared to ALL patients. We had obviously large number of patients, 53 patients and 15 patients of acute leukemia. We tried to match them from the age, and they were also quite well matched from their socioeconomic status, because everyone was mainly from Tata Memorial Hospital. This was like in 2004, 2005. And realized that in spite of not same age, in spite of at a baseline, whether you start radiation or whether you start chemotherapy at the time of diagnosis, a significant proportion of brain tumor patients indeed had a worse VQ, PQ, as well as full scale IQ as compared to leukemias, indicating that it is really the tumors, the brain tumor per se, which also can make a difference to their relatively poor IQ and poor neurocognitive function. And also perhaps because of surgery, that was the other difference, because most of our patients have had surgery before, while leukemias obviously didn't have surgery. So these were the two factors which could also possibly play a role. We have also realized over a period of time that age at diagnosis, certainly the younger the age, less than 3, less than 1, which is the tumor type? Is it midline tumor? Is it cellular tumor? Is it close to the middle cerebral artery territory? Is it how many times the surgery has been done, which is the grade? How much for how much time the tumor has been there, for example, in a chiasmatic hypothalamic glioma, or as compared to a posterior fossa ependymoma or a medulloblastoma? Is there an associated hydrocephalus? Has there been a shunting done or a drainage procedure? Has the child presented with seizure? Is the tumor stable or progressive or recurrent, and other therapies and comorbidities? What was also relevant, especially in younger children, as I already mentioned, that any factor of lower socioeconomic status, younger the age at diagnosis, supratentorial tumor location as compared to infratentorial, as well as the presence of cranial radiation in these patients in CNS survivors had a worse intellectual IQ function as compared to others. There is also a couple of interesting things which I want to tell you in this slide. First of all, there is a very good data in adults, not so strong in children, but in adults, there's a very fairly good data in low-grade gliomas that the poor IQ also has a direct correlation with quality of life of the patients. I mean, you can tell in children also, but I'm talking really from objective point of view. Those patients who have had prospective NCF, neurocognitive function testing done by the modern battery, and also underwent health-related quality of life, either by URTC, QLQC 30, BN20, or FACT, and there was a very good correlation between the two. sometimes the cognitive disability could be so profound that it will actually supersede the physical disabilities. And these are all very relevant points in this slide. It may not be seen on anatomical imaging. We frequently see the T2 weighted flare abnormality, sometimes even enhancements. Occasionally, you can see vascular microvasculopathies, microangiopathies on MRIs, but not always. About 30 to 40%, you may see them, but many times you may not see them. And this is relevant too. We also have to remember that it's not only the IQ which gets affected, the processing speed, working memory, attention, executive functioning, personality, affect, neurobehavioral slowing, and in older patients, not in children, of course, they can have very frank dementia seen as well in a relatively small percentage of patients. Two very important points, especially in children, which we have to remember. It is interesting to note that there is significantly more decline in patients, particularly after radiotherapy in childhood brain tumors, the children in whom there is a relatively high baseline value, which means that a child who has a very high IQ, after you irradiate, they will have a more decline than a child whose IQ is not so high as a baseline, will have a lesser decline. But in overall period of time, at a long term, after 3 years, 5 years, 10 years, even if the decline was more profound in children with higher baseline IQ levels, they still do much better than children in whom the IQ is relatively low. We have also struggled to some extent as to how the neurocognitive function battery should be. And it also depends upon whether it is a prospective study, whether it's a longitudinal study, it's a cross-sectional study, depends upon what we assess, when do we assess, and in whom we assess, the age, the tumor, whether it is controlled, whether radiation was given, how many surgeries, location. So in whom we assess, when we assess, and what we assess. So these all make some impact in the analysis of the neurocognitive function. Now, all of you know, and I don't have to emphasize too much, how critical from radiation point of view is the amount of total tumor dose that we deliver, and those in particular now, the critical structures, not only the whole brain, but the particular critical structure that we do. Fraction size, everyone can understand, whether it is both hypofractionation is not so great. There is a great thrust on hypofractionation, and I am also becoming a big fan of hypofractionated now in general for cancer, but in children, of course, you have to have a different strategy. The fraction size is very important in brain anyway, and sometimes there is some data on hyperfractionation too. Whether it is craniospinal, whether it's partial brain, whether it is conformal, what are the margins, what is the accuracy of your execution. We'll discuss a little bit about photons, and now that we have some interesting analysis of our own data from particle beam therapy in our country, I'll share some data with that as well. And finally, I will dwell a little bit more on the dose constraint models, which our group in Tata Memorial was involved in over a period of number of years, so as to be used in clinical practice to minimize the cognitive impairment. Now, as far as in childhood brain tumors are concerned, for that matter, even in adults, there have been a number of radiation-based strategies to minimize neurocognitive decline. In very young children, of course, we try to avoid radiation where we can, especially favorable histology, low burden of disease, if there are equally effective alternative treatments available. In adults, oligometastasis, minimized treatment. We know now we treat only the tumor bed, not the whole posterior fossa and medulloblastomas. Wherever we can reduce the doses of CSI in adults, primary CNS lymphoma, whole brain. And we also have collected very good evidence for modern technology, whether it is the imaging for using accurate delineation of the target, minimal PTV margins, high conformation by IMRT and protons, radiation therapy delivery either under stereotactic or nowadays with image guidance. And finally, very, very important, how can we avoid conformal avoidance of hippocampi, which is the main subject today. But equally, if not more importantly, the basal ganglia, the temporal lobes, the frontal lobes, all possible potential conformal avoidance structures. And we have now the means and ways and knowledge and strategy and the expertise and the experience to do all these effects so as to have the balance. You cannot go too extreme also, that you completely avoid radiation and then the tumor grows and then you give alternative therapies and then the tumor is so large that you have to eventually irradiate. It has to have that fine balance of effective and durable long-term tumor control, but also balanced out with least amount of toxicity, in particular neurocognition. Now, Dr. Merchant has done phenomenal body of work over a number of years, decades now, to evolve prospectively series of articles and series of work, in particular conformal radiation therapy in number of tumors. And we are all aware of this data of ependymomas, where in general in brain tumors, we were never irradiating less than 3 years of age. Now we routinely use in posterior fossa ependymomas, especially the PFA types, but sometimes in PFP who tend to be a little bit older, we use routinely radiation therapy in these patients, whether it is both protons, but also you can use IMRT. And this was particularly evidenced by the fact that he published series of articles. There is a recent update also on it. And there was very little cognitive decline, even when you treat less than 3 years of age. We now re-radiate posterior fossa ependymomas also with excellent IQ preservation rates. But this was really one of the preliminary data which has been corroborated and withstood the test of time over a period of data that we have collected. In our own series from India, which I was very fortunate to have phenomenal colleagues myself, we did this prospective randomized trial, but more important than randomized trial was also a good body of evidence that and good collection of data that we could accumulate over a period of time, again, looking at both using a relatively simple battery of neurocognitive, but also looked at neuropsychological function, physical activities of daily living, quality of life, survival, in both young children as well as slightly older adults, young adults up to 25 years of age. And this battery is well published and well known in many articles, and I'm sure some of you must have read it already. One of our earliest data when we presented was, which I already showed to you some extent, that we found that a significant proportion of our patients actually had a relatively poor IQ to begin with, but gratifyingly, at least the patients who were treated with the high precision radiation at that time, the most optimal and most modern technology of stereotactic conformal radiotherapy. This work started in 2001, and there was no decline, at least up to 2 years. There was some decline in anxiety, C1 anxiety, but not otherwise. The neurocognitive function of IQ was maintained. And you have all now seen this data that we have published already, a large number of patients, but more importantly was the endpoint that we chose. It was a critically relevant endpoint of neurocognition, psychological and neuroendocrine, and the secondary endpoint was survival. This has been already shown many times, but more importantly, we showed, perhaps for the first time in a randomized trial, producing very high level of evidence that a conventional radiation vis-a-vis a very high precision radiation at that point of time, the most appropriate under stereotactic guidance. Nowadays, we do image guidance. The principles remains the same. Highly conformal radiation, that time stereotactically, but these days image guided. And now you can extrapolate to IMRT and protons. It's not only the pretty picture on the computer that you get with very elegant dose distribution and the DVHs, but we have shown that with a clinically relevant endpoint with data measured prospectively up to 5 years, without compromising survival of more than 85 to 90% in both the arms, there was a significantly superior outcomes, both in terms of preservation of neurocognition in various domains and also preservation of neuroendocrine domain with the high precision technology. Dr. Indranil Maulik was phenomenal in this kind of work. He was the one who, along with Devnarayan Datta, who again was a very dear colleague of who worked a lot with me, we managed to show for the first time again in the world that there could be some correlation with temporal lobe doses. And perhaps for the first time, we tried to propose a model of left temporal lobe not receiving more than 43 gray to 13%. And interestingly, that time we didn't know, we just did a logistic regression model and found out to our surprise that there was some correlation of the left temporal lobe. And then we realized the left being the dominant lobe of the brain, and there was some correlation between the two. The strength of the data was the prospective nature, and without looking at it, we just collected the data, we analyzed in a relatively small number of patients, 28 patients with only 2-year follow-up, but even that gave us a kind of a proof of principle data that there could be something going on in some particular parts of the brain rather than looking at the whole DVH and looking at the radiation doses to the all parts of the brain. And this also is borne by the basic underlying pathophysiology of neurocognitive deficit, which we can see post-radiation. We knew that there is a transient decline in oligodendrocytes and, more importantly, the vascular endothelial cells. We also knew that there was some impact on myelin, neurons, astrocytes as well, and microglia. But we also had realized that it is not only the anatomical damage, there was a profound metabolic and developmental damage also happening because of post-radiation, the interplays, and could lead to atrophy and necrosis. There is a fair degree of neural inflammation. There is fair degree of hippocampal neurogenesis, which of course we have realized with quite a bit of robust data. But mind you, there is also non-hippocampal damage occurs. And we had data from the T2 flare abnormality in the white matter, which we already were aware. But it is important to know that all these processes are complex and they are dynamic. There is not one fixed static process after radiation, which is responsible for the deficit that these some of our children have. Now, justifiably and very rightly so, for the last 10 years, there has been tremendous amount of focus on hippocampus, and all of us know now that hippocampus is, is just the seahorse, the shape of like that. It has got from the dentes gyrus, it has the granular zone, and there's a molecular zone, and it is very close to the subventricular granular zone. And there are stem cells, there are neuroblasts, there are immature neurons. And what's more interesting to see in the white matter, particularly in the subcortex, that these neuron stem cell zones seem to be extremely sensitive to radiation. And a modest dose of radiation in animal data yielded a tremendous amount of apoptosis and decline in neurogenesis. Even when there was no frank demyelination or white matter necrosis, which we thought was the major underlying pathophysiological process, the loss of myelin, the loss of white matter, the loss of oligodendrocytes and microglia. But we thought that even if there was no frank demyelination, but there was apoptosis and decline in neurogenesis in the subgranular zone, that was also responsible because of radiation. And a lot of work came from Michelle Monet. She was in Stanford that time. And a lot of work was done from her group and some other groups as well. And just to give an example, that this was the control tissue, we gave 10 gray single fraction radiation. And what we saw was the Ki67 positive cells. So 0 gray is the sham dose, that, there's always a control, you give sham radiation, which means no radiation at all. And then you can see there were lots of positive cells. While as we gave 2 gray, 5 gray, 10 gray, there was a decline in positive cells with decreasing proliferating cells, and also DCX stain, which stands for neurons, very commonly used again in animal experiments. So there was an increased apoptosis and dense chromatin, there was decreased proliferating cells, and this was all in the hippocampus. And these cells were taken from the hippocampal stem cells, and this was one of the first experiments which showed that there was something going on with radiation, especially even with low dose of radiation. We always thought there was a threshold for very high dose, but in these animal experiments, we realized that even very modest dose of radiation can cause. And I mean, of course, we knew that there's a constant agenesis going on because hippocampal atrophy, we knew had a correlation with Alzheimer's, with neural degeneration, and also epilepsy. But we did not know so much that it had correlation from neurocognition in brain tumors per se, and that was quite revealing. And how to incorporate that data into routine clinical practice was this next challenge. And that credit goes to the group from University of Wisconsin-Madison, from Professor Vinesh Mehta's group. but Vinay Gandhi, who has done just unbelievable work on this subject, and Deepak Kuntia were among the first ones to show that can we avoid and use hippocampus as a conformal avoidance structure, that time using a helical tomotherapy approach. But now, of course, we can do it in many, many other approaches as well. In particular, that time, initially, as a whole brain radiation technology, because whole brain was a very important area. Alonso Guterres was the physicist that time, who actually happens to be the chief of physics at the Miami Cancer Institute with the proton beam therapy, and who is, we have a collaboration with them. But you can see this group with Wolfgang Thome, a physicist, Soren Benson, the famous statistician, Deepak and Minesh Mehta. And they had three objectives: that you could have whole brain dose radiation, there can be conformal avoidance, and you could still be able to deliver the radiation doses that you need to deliver to have effective tumor control from SRS point of view in brain metastasis. Then they, of course, went on to demonstrate that it can be done in a linear accelerator-based IMRT fashion almost to, and these images are very familiar these days now, how to draw the hippocampus, then you give the PRV margin, and all of us, I hope we do it routinely in clinical practice. We started doing it about 10 years ago, maybe more than 10 years ago in TMH, and I know many, many centers do now throughout the country. So we are all aware of these RTOG guidelines. You know, you typically use the MR fusion and CT. It is well, and that again, credit goes to Vinay Gandhi, because when they started the clinical trials, they wanted to make sure that the RTOG guidelines, initially published in American Journal of Clinical Oncology, AJCO, and then were subsequently incorporated in RTOG. And typically we start inferiorly. Everyone, you know, when we started, we went to our neuroradiologist, Dr. Sona, who some of you may know, and they always told us, that time RTOG Atlas was not there. They always told us when they drew the hippocampus for their epilepsy work, they always do it in the coronal section. That's how they were used to. But while radiation oncology, we are used in axial slices. So some of our earliest data contouring of hippocampus, we used her help to contour in coronal sections, and subsequently saw how it looks on the axial. Now we know we typically use the temporal horn because the anterior portion of the lateral ventricle is very well visualized, and hippocampus is just inside the curve of the horn near the gray matter, and that is how you start. Then you do inferiorly into the temporal horn, is always a very good structure, and then you keep on going superiorly. Mind you, it goes posterior superiorly like, and then you always keep on checking on the lateral, because you want to see whether it shades the shape of the horse that we are used to. And then you go to the amygdala, to a little bit guess there from the superior slices. The caudal most portion of the hippocampus, of course, we know is at the level almost to touching the brainstem, near the pons and the posterior part of the pituitary gland. And superiorly, all of us know, is the quadrigeminal cistern is an important structure, and the cranial most extent is at the splenium, at the posterior superior level. And these are some of the steps that are just a guideline to help you, but of course, all of you are familiar with it. Everyone has their own style to do it. And if you are, kind of a newcomer, I think the best thing is to go through the atlas. And most of the clinical trials usually have an appendix as to how to do it. And many people in the world are now familiar with it. I have to show you one or two data from the adult side, because that sparked the interest in childhood tumors as well. And this was among the first papers. And I remember when this data was presented at the SNO meeting in 2013, I think, or 12, I think 13. And Vinay Gandhi showed both in SNO as well as it was a WFNO meeting actually in San Francisco. I happened to be in the audience, and we were quite stunned with the data that was showed. It was a phase 2 non-randomized trial of only 100 patients. And retrospectively now thinking that there were several shortcomings of the trial. Only 42 patients we could complete the assessments. And it had to be correlated with the historical cohort. And they saw the HV et al., the Hopkins verbal learning test, delayed recall, because in adults, the memory is an important quotient. But nevertheless, it was exciting and was subsequently published in the JCO next year. to show as a proof of principle that indeed there is something going on there, and you can possibly reduce the neurocognitive impairment. And that time, Vikas Kothawade was my MD student, and we gave him this thesis that which technique is perhaps the most optimal. And he did a very good work, dosimetric comparisons of series of patients using that time we were very fond of stereotactic conformal radiotherapy, but we are also doing a lot of work in IMRT, LINAC-based and tomotherapy. And it was very apparent that the tomotherapy and IMRT yielded much better hippocampal sparing as compared to the forward planning SCRT, and inverse planning was obviously the way to go. Vinay also published at that time, again in adults though, but among the first papers in Red Journal about benign and low grade in a relatively small cohort of patients, and only 1.5 years of follow-up of neurocognitive function, and again used the Wechsler memory scale as an endpoint. Memory scale, mind you, after 16 years of age, the Wechsler scale, the memory scale, is taken into consideration. And he came up with a figure of 7.3 gray as the bilateral hippocampi EQ due to 40%. And we had some differences because it was a relatively small number of adults, but nevertheless, it was an exciting piece of work which stirred the interest of many researchers throughout the world, including yours truly. Now, then this data came from St. Jude's, was published last year. Again, was very well received throughout the world in the neuro-oncology circles. I go back to the pediatrics because I have to show you some of the adult slides because hippocampal data came from there. It was a good number of patients, 80, and childhood population up to 21 years of age, classic dose of 54 gray. The follow-up was very impressive, 9.8 years, but the greatest, some drawback was it was retrospective. However, on multivariate regression, they found out that the short delay recall was associated with V40. So the volume of the 40 gray and how much of the hippocampus is that, both on the right as well as on the left. So they showed correlation between both the two. Now, some of you may have seen this work, which was published earlier this year. And again, many people have asked me this data throughout the world. So the advantages of this data set is that this is among the few trials or few studies which were prospective in nature. There was a baseline pre-radiation data collected, and we sequentially collected the data at 3 to 6 months post-radiation and then annually for 5 years. And this is perhaps, I was told that it's among the only data which has 5-year prospective data collection. We again had, it was based all, of course, from the SCRT trial. We retrospectively drew the hippocampi because that time when we did the trial, we didn't know the significance of hippocampus. And we analyzed the data, and Dr. Jayant Godashastri, Dev Narayan Uday, with Savita and others have been phenomenal in analyzing this data very painstakingly, and found out that the significance starts coming at about 2 years or so, and then the full scale IQ starts coming at 3 years, and at 5 years both the full scale and performance IQ has a strong correlation with more than 10%, which is considered to be a clinically relevant drop in the cognition. And what was interesting that it happened mainly in the hippocampus. And one could argue that it could be because of many reasons, because the St. Jude data showed on the right hippocampus too, but they had a mixed cohort of patients, and they also had, as I mentioned, a retrospective nature, which can have some limitations. But nevertheless, this I have already shown you that there was remarkable correlation between the data. We also went on to see on a multivariate analysis what could be the potential factors which can influence. So clearly the age, the younger the age, had a correlation of poor cognition. Craniopharyngiomas were worse than glioma. So essentially younger patients, cellular supracellular tumors, particularly craniopharyngiomas than compared to others, and the dose to the left hippocampus. And we felt that the mean dose, and it was very simple because hippocampus is only 2.5 cc. So it is very difficult to break it down to different dose levels. So if you take, in fact, it was actually D50. So the 50% of the dose to the mean dose to the hippocampus had a strong correlation with a threshold of 30 gray. Now, that doesn't mean that 30 gray is, I do believe, based on the animal data, that it should follow the principles of Felara, as low as reasonably achievable. And although it might 30 gray sounds kind of easy to practice, and sometimes even 30 gray is very difficult to practice in very large craniopharyngiomas or left-sided tumors, in low-grade gliomas. Sometimes it is very, even especially if the target volume itself is encroaching upon the hippocampus, it is very hard to achieve this constant. But in many other sites, for example, in ependymomas, in meduloblastoma posterior fossa boost, of course, after CSI, in relatively small midline tumors, in germ cell tumors, in intracranial germ cell tumors, when we do whole ventricular radiation, some of these constants could be borne in mind to help you in your routine clinical practice. Dr. Utpal Gaikwad, who works with me here now and was instrumental in helping me to prepare this talk, was also instrumental in doing another beautiful study, which we call TMH shape study. This was again a prospective study sparing hippocampi in adult pituitary adenomas. And I know it's again, I'm talking to adult, but the audience, we have a mixed audience today. They do both adults and pediatrics. So this was a prospective study. Whenever you have to irradiate pituitary adenomas, we give only 45 gray. You do a baseline neurocognitive function. Purposefully, you spare the hippocampus with whatever best technology you have that time, but mainly with tomotherapy. And we do both a quality of life assessment as well as a neurocognitive assessment. We have completed this data of 50 patients, mainly using the image-guided IMRT technology. We have a median follow-up of this data was presented in Astro a couple of years ago with only 12 months, but now the data is for more than 3 years. And this paper is being written up. The manuscript is ready to go for publication, submission for publication anytime, maybe in the next month or two. And this could again be a very important, hopefully an important piece of work which may find some resonance throughout with our colleagues, perhaps even in other parts of the world too, who treat a lot of pituitary adenomas. And this also would have some impact in our routine practice. Interestingly, there has been also fascinating work on other aspects of hippocampus. This caught our imagination because this group from the US, what they did was, so it's from the UK, what they did was they did serial MRI scans and tried to see what is the atrophy happening on the hippocampal volume over a period of time. And they had, again, changes with respect to the radiation doses and also the age. The younger the age, they had more profound hippocampal atrophy. And also they had changes in the volume. Now, unfortunately, in our data set, we did not do too many MRI scans. We did one MRI after radiation and then just once or twice again, not serially every 6 months. We did neurocognitive function serially every year, but not MRI scans. And I wish we had done MRI scans because you could prospectively measure the volume of atrophy in the hippocampal volume. And we had the baseline volumes, and that would be very interesting. So this is a good piece of work if someone is interested, my younger colleagues who are listening to this, this webinar. This could be a beautiful piece of work if you can do prospectively and measure by three-dimensional volumetric analysis these days. Most of the modern imaging platforms possess, and that could be quite interesting as well. What was also interesting, this data came from Korea, and this was not in brain tumor, this was in carcinoma nasopharynx, interestingly. And what they wanted to see was that which part of the hippocampus is important. Is it the head? Is it the body? Is it the tail? And obviously the body is more, you can see it about 50%, 45% of it is the body, but there's also other parts, the head and the tail. Because of the hippocampus, the nasopharynx, they found out the head had more correlation. But we have realized now, and that is again a very good piece of work, can we show the differential constraints to different parts of the hippocampus within the left and right as well, and perhaps a grid or a nomogram which would incorporate age, the location, the tumor type, the duration of the symptoms, the type of surgery, and also the dose constraint within different parts of the hippocampus. And with imaging, you do at baseline and then you keep on measuring it over a period of time and then see the flexibility or see the volume change in the hippocampus and also in the non-hippocampal areas of the brain. And that would be quite neat to show because you could possibly have a differential dose constraint to different parts. As I mentioned, this particular group, Scientific Reports, is a very nice journal published by the Nature group. And they're just thought-provoking proof of principle studies. And this is kind of a proof of principle studies to bifurcate or to divide the hippocampus in 3 different regions. And this has to be validated, of course, in a prospective fashion in many other sites. I do want to talk a little bit about meduloblastoma, just 1 or 2 slides, because we now realize that meduloblastoma is no longer one disease. It is 4 distinct, actually more than 4 these days now, depending upon whether sonic hedgehog has P53 mutation, whether it has MYC implication because SHH can be standard risk or a high or very high risk if it has P53 mutation as compared to wild type P53. Group 3 is particularly bad, but especially if it is metastatic, and group 4 was also considered to be high risk, but we have realized now that if they have chromosome 11 loss and it's non-metastatic, they don't do so badly. So this is the modern way to treat medulloblastomas because you can do molecular stratification to drive your doses. The CSI doses are being tested by various series to reduce to 15 to 18 gray, and this is a de-escalation therapy. Now you can ask me what is the relevance for hippocampus, and the relevance comes from this fascinating piece of work, which was a joint effort from sick kids in Canada and some of the centers in US, especially Baylor and MD Anderson in Houston. They collected the data, treated of about 79, 80 odd patients, less than 79 patients, about half of them treated with proton beam therapy and half of them treated with radiation therapy, the photon beam therapy. And they were obviously non-randomized, but this was longitudinal intelligence data. So again, gives the power of prospective data collection. And what was surprising, because we always, even myself, I always believed in medulloblastomas, there is no way you can reduce even with protons because you treat the whole craniospinal axis with whole brain, you give the boost to the tumor bed, it would not make too much difference whether you do proton and photon. But in this group of patients, they realized when they collected the neurocognitive data over a period of time, and this is fairly long period of time, you can see the years are 7.5 to 10 years, although vast majority of the data has been collected in the initial period, 2, 3, 4 years, looking at the scatter plot. But it became apparent that even the proton group, even in CSI, there was a superior long-term outcome in terms of neurocognition. So we are breaking our head that how is it possible? And one of the postulations is that when you do protocol determined conformal tumor boost, but boost especially with proton, because of the rapid follow of the proton beam therapy, there is perhaps less dose to the hippocampus, there is less dose to the temporal lobe, there is less dose to the supratentorial brain, and that could possibly relate to superior intellectual outcome. This has to be tested in a prospective fashion, and we are looking forward to do the same in our center. But I know there are other centers in the world who are looking at it prospectively as well. Tom Merchant, of course, had shown that there is a superiority of some of the domains, not all, with protons, especially in the reading scores and math scores, as compared to photon in a non-randomized fashion. And it is hard to do randomized trials in proton, but our SCRT trial should be a proof of principle. You don't necessarily do a randomized trial with proton because we have shown dosimetric superiority with carefully chosen clinical endpoint are equivalent. So if there is dosimetric superiority, there should be improvement in some of the clinically relevant endpoints. This was a data which I had the pleasure, along with my colleague Jayant, to write an editorial on. Was a good number of patients, 125 patients treated with proton beam therapy. Again, a comparison between external radiation from Chicago again, Vinay Gandhi's group, who heads the proton therapy center there. Although again, not a randomized fashion, but fairly well balanced between different factors in terms of their demographics and the type of treatment that they received. It was apparent that on a number of scales, and this is mainly in children, in pediatric brain tumors, whether it is full scale IQ, it is processing speed, it is the short term memory, it is the visual motor integration, calculations, the conceptual, social, and practical domains. In most of the cases, most of the domains, proton beam therapy scored significantly superior to external beam radiation therapy with photons, and that could be considered for proton as well. And as I mentioned, we wrote an editorial on it, and we argued that modern proton therapy does preserve NCF and quality of life in these long-term survivors with cure with long-term safety, because the local controls were not compromised. Some of the other data from proton beam therapy for pediatric patients in particular has come from different groups. This is data from Dana-Farber and Mass General in Boston. 60 odd patients, but a mixed group of medullos, gliomas, ependymomas, cranios. But they looked at the cognitive baseline at 6 months, and there was no difference, of course, but it is prospective. The earlier data which I showed you was retrospective. So always, even if the number of patients is relatively small, but the strength of the manuscript comes from the prospective data collection. And even if it is relatively early follow-up, but I'm sure the follow-up will increase, and this will give us confidence in proton beam therapy. I also should emphasize that, which I've shown in many of my presentations, that there is a proton and there is a proton. The vast majority of the data in the past, even from Chicago and Boston group, has come, in MD Anderson group also, has come from passive scatter technology. And there's a big difference between passive scattering and the most modern contemporary radiation technology of proton beam therapy using image-guided pencil beam technology, which is a very small, fine pencil beam, and with different energies also raised. You can do, we call it spot by spot, line by line, layer by layer. You slice it, and the spot goes here and there and treats it three-dimensionally in a very nice fashion. We always use Monte Carlo not only for the calculation, but we also use for every case for optimization. We have more or less moved away from PTB margins. We use routinely the robust optimization for our patients, and of course has the cone beam CT with rotational gantry. And there is data from proton beam therapy in particular to spare the hippocampi for craniopharyngiomas. This was one of our first children that we treated with a craniopharyngioma, and then you have to, of course, have a class solution, because you have to know where the beams are coming from instead of a rotational VMAT technology that we are otherwise used to in the photon world. Try to avoid the beams through the shunt, because the density of the material proton doesn't like. It can impede the travel time, and it can stop and perturb the dose distributions. Some of the basic principles that we use, it gives a fantastic dose distributions, and the doses to the hippocampus. We had several proton plans with relatively simple beam arrangements, usually 2 to 3 fields, and the left hippocampus was about 5 gray. And mind you, our data was 30 gray mean dose. These are the mean doses and phenomenally low doses, especially in supracellular tumors where the hippocampus is literally hugging the target. Such a rapid fall of the dose if you can plan it properly, which used to be a dream in photon world, whether I wish, because when you achieve these doses, the low dose wash used to be, a wash. I mean, as you can see it here, we compared it with the tomotherapy plan, and the low dose volume was all over the place as compared to a relatively small beaks. And then you put the beams in such a way from the anterior in this way, such that you spare the hippocampi and the beams don't end there because of the beam uncertainty. And these are the tricks that you will learn over a period of time in the proton world. And IMPT scored massively over the IMRT technology. In older people, in favorable gliomas, also it is being tested in a randomized fashion, what is called the NRG BN005 study. And this will also, again, throw some data from the hippocampus. We also quickly run through the what I showed you, the Vinegondi's earlier data on the just a phase 2 trial. Now we know that it has been tested in a phase 3 NRG trial, CC001, and there is significant superiority of whole brain using hippocampus. Now this was interesting, and I give credit to Utpal to search this data. I was not aware of this paper. And what it is a survey of radiation oncology in the US, a good number, almost 200 people. And they asked them, what are the hesitations of not drawing hippocampus or not using hippocampus as a routine planning for IMRT? And 60% of them said that it is too time consuming. 63% said you need thin slice CT and MR, the insurance or the other don't pay it. Again, 60% said you need superior or better dosimetric and physics support. But as in America, as we all know, there was increased cost and limited insurance coverage. So it was kind of a little bit of made me a little bit sad that in spite of overwhelming data, and this was for whole brain in metastasis, and in all the more reason in childhood brain tumors where you have to treat them prospectively using as low dose to the hippocampus because they will live forever, and it is pertinent and critical to spare all sorts of normal tissues, including hippocampi in particular. I showed you how sensitive they are to the radiation, especially in a younger child. And this was quite interesting that in spite of the fact that vast majority did believe that you should spare the hippocampus, but very few people actually did it, about 40% or so. In small cell lung cancer, there is some fascinating data as well. Some people think that you can spare the data, and some people think that Kristen Redmond showed actually that 2 patients developed metastasis, and the Swedish group showed that Switzerland group showed that there isn't any case, is of course being tested in a randomized phase 2, phase 3 trial currently in small cell lung cancer. Finally, I do want to tell my colleagues that it's not only the tumor, it's not only the radiation sometimes, it can be also the tumor regrowth. There's a fair amount of data that the neurocognitive decline can be the harbinger of a tumor recurrence in a short period of time. So whenever you have a neurocognitive decline, may not be only radiation in a prospective fashion, especially in high-grade gliomas, including in children, that can signify a profound risk of having a tumor recurrence. And we also know the impact of AEDs, especially in childhood tumors, the use of anti-epileptics can, there's an interplay between the seizures as well as the AEDs in the neurocognition. Fascinating piece of work from my friend Don Mabbott from Sick Kids in Toronto showed in a very simple fashion that in children, again, what they did was in animal data, they found out that the exercise training with mice, they made them exercise, there was a regenesis of the hippocampus. It was remarkable that you could give radiation, the hippocampus used to shrink. You do exercise of the mice, the hippocampus again regains. It was fascinating to see. This is being tested in a clinical fashion now, and in Toronto, what they do in the clinical trial, while they are waiting for radiation, they are asked them to go to the gym, the children, and they spend some time there doing just exercise before every day for radiation, because it's a captive audience, cranos and gliomas and ependymomas and medullos, while they are waiting for their radiation turn to come. This is again a neat piece of work which we can do. And also there is a lot of work on cognitive remediation therapy, what's called CogMed. I've particularly seen it. There are differences. CogMed therapies, both in children, are separate. There's a lot of data in digital space out there, how to incorporate in adults from the working memory and for cognition in terms of children. And finally, it is not only the hippocampus, it is the other areas as well. As I mentioned, it is the neural progenitor cell containing niches. It could be the subgranular zone. It could be the SVZ, which we were trying to use it in gliomas, in high-grade gliomas, but it's also the frontal lobe. It is also the basal ganglia. It is the putamen. It is the other areas which we have absolutely no idea how much is the component, what is the dose constraint in those lines, and that is very important to see. Ajit Kumar, my erstwhile colleague in UK, actually published this very nice paper in Lancet Oncology a few years ago, trying to show how critical it is to incorporate modern imaging technology of tractography, perfusion, and so on and so others in order to integrate the two. So in conclusion, I hope I have been able to demonstrate that cognitive neurocognitive failure is a formidable challenge in pediatric brain tumors and is a very important survivorship issue. In children and young adults, especially, we try to avoid or delay radiation or try to reduce the doses as much as possible, whether it is because of the chemotherapy or because of the molecular subtype they have. Modern radiation techniques, there is now level 1 evidence based on our own data that the lesser the doses you give to the critical structures, the better is the cognitive function. It also, we have demonstrated what could be the specific areas of the brain which could act as a conformal avoidance. And now we have fairly robust data on the dose constraints, but the more work is to be used that what part of the hippocampus should receive how much dose. Is it only the hippocampus? Does it depend upon, is there any dynamic process in a prospective fashion with respect to the age, the location, the tumor, and the previous treatments, and the AEDs and steroids, and so on and so forth. Also, the baseline IQ level and how it goes over a period of time, the use of shunts, the use of multiple surgeries. This is almost a very complex strategy that we may have to adopt. Judiciously, sometimes you could use pharmacotherapeutic agents, although the data is relatively weak in children, slightly more strong in adults, and there's a lot of thrust in cognitive rehabilitation as well, even before radiation. As I mentioned, it's just physical exercise, but there can be a mental or cognitive exercise as well. Because, and I have shown this slide a few times before, that in cancer research in general, what should be the real endpoint? We always talk about survival and PFS, and we use the CTC, the acute toxicity, even the chronic toxicity. In the last 10, 15 years, we have used now fairly robust medical endpoints of cognition, endocrine, our own trial, for example, but stroke and vascular events and second malignant neoplasms. And this was a fascinating piece of work being done by Tom Merchant again at St. Jude's, where the primary objective of the trial using proton in cranio is not only the PFS and OS, but it is the clinical significant vasculopathy. And vasculopathy is not only the stroke, but it also has implication in neurocognition and permanent neurological conditions, and also the psychological and psychiatric issues. But actually the long term, which my erstwhile colleague Priya and I argued in our paper, that the futuristic endpoint should actually not even be that. The endpoint in any medical intervention or clinical trial is not only the survival and other things, but could it be what are the chances of employment of that child when he grows or she grows? What are the chances of retaining neurocognition? What are the chances of retaining memory such that they can have a stable financial, social independence and a personal relationship, not only for some time, but as a long-term durable stability? And I don't think we are ready for using these endpoints in clinical trials, but just food for thought at the end for my younger colleagues, because they are our future, and I hope some of them take upon these endpoints as their, not only the medical, but the social endpoint of any intervention in their academic work. And with that, I thank you all for your attention.
Thank you so much, sir, for your excellent deliberation and teaching. Do you have some time for taking few questions, sir?
Yes, I can answer some questions.
Thank you, sir. So the first question is from Dr. Mukti Mukherjee. Is there any role of memantine in young patients, and if yes, the dose?
So memantine has not been used so popularly in children. It has been used mainly in adults. And I have never used memantine in children. Some people have used memantine and other drugs as well, but the data is not very strong. So I wouldn't advise using it routinely.
Thank you so much, sir. There is a comment from Dr. Indu Bansal, ma'am. Excellent presentation, phenomenal work as always. Thank you, ma'am. So regarding this proton, I think definitely it has changed the practice of radiation oncology a lot and the expectations also. Now, do you want to also put forward some cautionary notes about the safety points or safety measures? If they are not followed, then how can it be dangerous? Like if there is a very crucial organ at risk immediately after the target, so how can it be dangerous if the things are not taken care of adequately?
This is an important point. And especially 5-10 years ago, it was extremely relevant because there was a relatively high risk of, for example, brainstem injury. Some of you already may know. And it primarily depends upon the end of the Bragg peak. There is uncertainty of the dose. So we do not know the RBE there because it can range, the range uncertainty is there, and you don't quite know where will exactly end. So it was more relevant in the earlier technology, especially with the passive scattering and even in uniform scanning. And we had some issues with it. So there are two great things what has happened, or three great things. Number one, there's a tremendous amount of care and meticulousness, which most of the proton beam therapy people would employ in the world. And if you look at the last 5-year data, especially using the pencil beam technology, the risk is practically, it's extremely low. You can see that in photons too. So while there is still some uncertainty, but the uncertainty is much significantly lower because the knowledge is there. You try to avoid the beams where you end. You try to put extra beams. You want to feather it, and there are ways and means to do it. That is number one. Number two is the introduction of the pencil beam, because most of this was seen in the earlier technology, as I mentioned. And the modern technology of using pencil beam has greatly minimized this risk. And the third is actually the planning systems. The planning systems have evolved marvelously as well. The use of Monte Carlo, for example, and in future maybe some form of RB or LET based optimization too. But Monte Carlo itself has helped a great deal to minimize this risk. Nevertheless, you have to be careful. I mentioned some points. For example, if there is any change in the density, you have to, if there is any metal, if there is any shunt. We do QA CTs and QA MRs typically anywhere between 3 to 5 or even 6, because during the radiation almost every week, and many a times we have to adapt. So there's a fair amount of adaptive radiotherapy being employed, because it can perturb the doses and it can change both to the overdose in a critical structure, but can also underdose. Fortunately, maybe we trained in such a way, and maybe we were very fortunate also. The modern proton beam therapy proponents and users, because that particular risk is now more or less taken care of. And we haven't had any issues at all, fortunately, in the data, the 200 odd patients that we have treated, with a fairly large number of CNS tumors as well. So, but of course, we have a relatively short follow-up, but other centers who have used similar platforms. Therefore, I try to emphasize the need for training, the need for care, as you rightly said, that meticulousness, that thinking process that this might happen otherwise, aided by the improvement in the technology and the knowledge sharing, has greatly and significantly mitigated this fear.
Excellent, sir. Another thing which I'd like to know from you about the quality of image verification with this current proton beam therapy systems you are having at your center. So, so when I was working with proton system in that time also, I was there in Abramson's proton center, and the kind of CBCT quality that time in 2017, I think it was kind of very rudimentary imaging system, and the quality of CBCT with conventional Linux were much better. So would you like to have any comments on this?
So the problem is we have been spoiled, the photon people. So what happened, unfortunately, in the proton beam therapy world is that there was a relatively compartmentalization of the proton physics, even the medical teams and engineers, as compared to photon. They were not together. If you look at the Loma Linda, Mass General, PSI, Japanese, and some of these centers, they were working in kind of almost in a silo. And the photon technology had improved so dramatically, especially from the image guidance. And so you're absolutely right. I was shocked when we started. I'm entering the field about three and a half years ago now, and that more than 50% of the proton facilities that time did not have an image guidance, and they were still using X-rays. And while being super precise, and they didn't have a fundamental, and then they tried to introduce, as you rightly said, some image guidance. So the ones like us who have migrated from the photon to the proton, it does, we always look at the image guidance is not the best, and you're absolutely right, because the quality that we expect is not that level that we are used to. However, the proton, because now in the last 5 years there has been a tremendous amount of synergy between the two. Some of the companies also make both now. For example, Varian, although now it has been taken over by Siemens, but at least they had a major portfolio on proton. So that helped for the other companies like IBA, which we have, also to step up, and also the Mitsubishi and Toshiba and Hitachi, that they have a very, very fine image guidance systems now in place as well. So in our setup, the image guidance is I wouldn't say it is like 10 out of 10, but it is 8 out of 10. It's pretty good. We still find a little bit faults here and there, but it is certainly much better that we have seen in the papers, and people like you and others who have experience in, say, 5 years ago centers. It is significantly better, and we have quite a few visitors who come from all over the world to see our center, and all of them comment the same, that the people who worked in erstwhile proton centers, they are pleasantly surprised and impressed with the image quality with the modern center. So it is definitely much better. Fortunately, it is one of those things which can be easily changed. It's not a big deal. There's nothing to do with a beamline or a proton generation or a cyclotron. The image guidance component is relatively easy to fix, and that we have already done. We also use now routinely the surface guided radiotherapy in some of these, not in brain, of course, but in other sites. And that has helped as well to some extent.
Thank you, sir. Dr. Animesh Shah from Kolkata has a question. Is there any evidence that proton beam therapy improves overall survival in any brain tumor compared to optimally planned photon beam therapy?
So survival advantage has not been shown, nor do we expect, because we are not escalating the doses. We are giving same to same doses. If you do not escalate the dose, it is not possible to expect improvement in survival. However, there are 3 areas of current intense research, 3 sites where there is a hope. I mean, as all of us know, there is a unequivocal improvement in quality of life, the reduction of cognitive, endocrine growth, and so on and so forth, and vasculopathies, second malignant neoplasms. And because there is no comparison of dose escalation, so therefore there is no evidence. But there are 3 sites, as I mentioned, where people are actively pursuing and escalated doses where there could be an improvement in survival. In fact, there is one site where there is already an improvement in survival, I should say, and that is skull-based tumors, chordomas and chondrosarcomas. There is a very good correlation with the dose threshold as well as the survival, and we have seen it already in there's no randomized trial, but if you collect the data every 5 years and 10 years, there is an improvement from only radiation, and you only 50, 60 gray or so, you could expect about 45, 50, 10-year survival in chordomas, and a little bit better in chondrosarcomas. And then the proton beam therapy traditionally used to give much higher doses. And nowadays, as you know, we traditionally give 72 to even 76 gray, especially with a higher dose per fraction with SIB, and which is about 75, 78, even 80 gray equivalent sometimes. And that is a dose escalation matrix that we adopt. That has definitely improved the survival by about 10, 15, maybe even 20%. I'll give you one piece of evidence, which comes from PSI Zurich in chordomas and chondrosarcomas with the erstwhile technology of passive scattering, and compared with the modern IMPT, intensity modulated proton beam therapy. The 7 or 10 years, it's published data, in chordomas is now about 80 odd percent, more than 80%, which is good 20-25% chunk improvement in the best data that we have ever had with any radiation technology. and in chondrosarcoma, it exceeds 90%. So there is that body of evidence. That is number one. Number two, at the moment, we are looking at dose escalation in anaplastic meningiomas, as well as in some of the very difficult recurring atypical meningiomas or hemangiopericytomas. And there is data to suggest that the dose equivalence of 72 gray is being tested. It's called Panama study. And we are looking forward to the data from this study that at dose escalation, which is possible only with proton, could translate into improvement in survival. And finally, even in gliomas, even in glioblastoma, an ongoing NRG trial of BN001 is examining dose escalation again in excess of 70 gray, although all the dose escalation studies in GBMs were negative. But this allows, it's a relatively complex trial design. You could do it both with photons and protons, depending upon what technology you have, and whether depending upon the volume and the site that you can safely deliver that amount of radiation dose. And it will take few years for it to finish the accrual and the follow, but in GBMs, you don't need too much follow-up. 2.5 years is enough. And hopefully, and we are all praying that in difficult diseases like GBM, some data. So at least in 3 sites, skull-based tumors, chondrocardosarcomas, which is already out there, the dose escalation does improve survival. The anaplastic meningiomas, atypical meningiomas, hemangiopericytomas, and in some of the high-grade gliomas, the studies are ongoing, whether we can exploit this technology to improve survival.
Thank you, sir. It's almost 9:15. Would you like to have another 2 or 3 questions?
Yes, please.
Okay, thank you, sir. So Dr. Indu Bansal has a question regarding adaptive radiation with protons in brain tumor. Which cases do you select?
So adaptive is not necessary from not like head and neck or prostate or other sites, but we do sometimes have to plan adapt, especially if there is a fluctuation in there is sometimes a pseudomeningocele, and you all of us know that can fluctuate a little bit in gliomas, or for that matter, any site. Even the posterior fossa tumors, we sometimes have to do another plan to adapt accordingly, according to the shape and contour, if the QA-CT and QA-MR shows us perturbation of the dose. Second indication is if there is a change in the cyst or component in a craniopharyngioma, or sometimes in a pylocytic astrocytoma. If you have to irradiate, there's a bit of cyst and there's a little bit difference in the change in the cyst. Even if there's a shrinkage of the cyst, that can perturb the dose, because the proton can go, and if it is close to a chiasm or a brainstem, then it can cause problems. So you have to replan. The third indication also is in chordomas and chondrosarcomas, and both in spine tumors and in the base of skull. Sometimes there could be a change, and then you have to adapt according to the contour. We have also seen occasionally to adapt in craniospinal with boost. Typically, I would start with boost in a meduloblastoma. That time, sometimes the neck is not at a very straight level. There's a bit of angle because the child is recovering from the surgery. And then typically after 4 or 5 sittings, we will do a QA-MR. And then if by chance the neck is straight, we cannot use the same for CSI, because even a small, Dodal, you know this because you have worked in proton, a small change in curvature can completely change the proton plan. So fortunately, our systems and SOPs are fairly robust. And right from the therapist point of view to the doctors and the physicists, the systems are in place to take care of these.
Thank you, sir. Another question from Dr. Deepak Agarwal regarding how do you propose dose constraint for hippocampus in a re-irradiation setting?
Very difficult, and I have struggled with it, and there is no frank answer, because it is the hippocampus usually does not forget the previous dose as compared to other parts. So in the cortical part of the brain, you could argue that there could be a regeneration of both the gray matter in particular. White matter is difficult, but sometimes, and you see the volume of the previous irradiated, the DFI and the previous radiation, therefore you re-radiate. Hippocampus, there is, to the best of my knowledge, there is not such data as to how you should do it. And many times the first radiation plan may not be there, or even if you have there, you may not have consciously contoured the hippocampus and try to avoid it. So it is a difficult situation. This has come to my clinical practice also, because we sometimes get re-radiation cases, both for photons and protons. So we adopt, you have to adopt, of course, the balance between the two in a child, especially. For example, a brainstem glioma, you don't worry too much about it because its re-radiation is mainly palliative. In a high-grade gliomas, re-radiation again is kind of, you don't really achieve so much remarkable survival. The only tumor where I struggle a lot in this is if you have to re-radiate an ependymoma. For example, in craniopharyngiomas or in other gliomas, the data is so nice that you hardly ever have to re-radiate. So the only re-radiation comes in ependymomas if it is a posterior fossa ependymoma, which is traditionally very difficult to treat and many times have to be re-radiated, and the children are usually less than 5. But fortunately, if you have treated well, because it is away from the hippocampus, even with photon, and if you have treated with proton, of course, that is much better from the re-radiation perspective, then you have to adopt the principles of Alara. As low as possible, you can go for re-radiation in a potentially curable tumor like an ependymoma. Even with the re-radiation, you expect a little bit better outcome. If it is a pure palliative situation of re-radiation in a brainstem glioma or a GBM or an anaplastic astro or a PNET or a medullo, then hippocampus really is not the major endpoint that you are looking, because you are looking at a modest improvement in outcome in terms mainly from palliation point of view. I hope I'm able to transmit the importance of hippocampus in that situation. So it's not a big deal in that clinical scenario.
Thank you so much, sir. If you allow me, sir, just I want to add one comment at the end of your presentation.
Sure,
that,
of course.
Regarding this particle beam therapy and proton therapy, perhaps we are still not in a position to accept this thing. And somewhere I read about 3 stages of truth, how truth evolves. When something new comes in, then there is a stage of resistance, then there is a stage of ridicule, and then gradually the truth becomes self-evident. I think the same logic may be applicable to this particle beam therapy, that we need to go still further, another couple of years, that beyond survival, there are more issues like quality of life, complications of treatment, and if we accept the dosimetry as an indicator, then definitely proton surpasses everything as of now, carbon surpasses everything as of now, if we compare with photon. So I think, sir, that may be the thing after a couple of years.
I agree with you. But the data is very compelling now. I tried to show you some of the data recently. There is a number of publications in the last 1 year or so, in particular for childhood brain tumors, for both prospective as retrospective, showing improvement in cognition, growth, local control. Everything is far better.
Very true, sir, very true.
COG protocols, many of the national guidelines, the insurance companies. I mean, cost is an issue in our country, of course, but if you keep the cost on the side, per se technology, particularly with the modern proton, there was some uncertainty in the previous, and with the knowledge base that we have and the expertise that we have now, it should really be in the mind of every single childhood brain tumor, should definitely be considered. For all that matter, for all childhood cancers, whenever they need radiation, they certainly must be considered for proton beam therapy.
Very true, sir. Thank you so much once again. And it's quite late and you are still sitting in your office.
No problem. It was a pleasure.
Thank you so much, sir.
Thank you. Thank you all. Good night.
Thank you, everyone, and good night to all of you. Good night, sir.
Good night.